Hello guys, now we'll be discussing a topic of aortic aneurysm. So before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us, which are very helpful for quick revision. And the link for the notes is given in the description below. You can download it from there. So without further delay, let's get started. So what are aneurysms or aortic aneurysm? So aortic aneurysm is a permanent localized dilatation of aorta to a diameter that is more than equal to 50% than the normal anatomic level. So if the caliber of the aorta is more than 50% than the normal of that anatomical level, then it is called an aneurysm and it is permanent. So what are the types? It could be a true aneurysm or a false aneurysm or pseudo aneurysm. So in true aneurysm, all three layers of the aortic wall will be involved. So it could be fusiform saccular with focal outpouching or fusiform, or false or pseudoaneurysm where there is leak in the aortic wall contained by the outer layer of the aorta or periaortic tissue. So all three layers are not involved here. Then causes atherosclerosis. Then there could be other like non-specific medial degeneration. Cause factors that are age, male sex, smoking, family history and hypertension. These increase the risk. Connective tissue disorders like Marfan's, Lloydites, Ehlers-Danlos, Turner's, thoracic aortic aneurysm familial, or congenital bicuspid aortic valve syndrome. So these are some of the connective tissue disorder. Then aortitis could be due to Takayasu or giant cell. Infections that could be mycotic, fungal, bacterial endocarditis through staph, strepto, salmonella, and previously syphilis also caused this. Trauma, that is pseudoaneurysm. Location could be thoracic or abdominal. We have to consider Laplace law in this, where tension is equal to pressure into radius. So as per that, the risk will increase as the radius increases or pressure increases. So that is hypertension and size causing risk of rupture. Now coming to abdominal aortic aneurysm, most common location is infrarenal aorta. 90% is fusiform. Pathological focal dilatation of the aorta of more than 3 centimeter or 1.5 times the diameter of the adjacent normal aorta. So normal aorta is 2 to 3 centimeter. If there is small abdominal aortic aneurysm, it is 3 to 5 centimeter. Moderate is 5 to 6 centimeter, large is 6 to 7, and very large is more than 7 centimeter. And annual risk of rupture in small is 1%, and in very large it is more than 10%. And 5-year risk of rupture in small is 5 to 10%, and in very large it is around 100%. In large it is around 50%, and in moderate it is 30 to 40%. So what is the risk factors for development of these aneurysm? So first of all, tobacco, hypercholesterolemia, hypertension, male gender and family history. For expansion, the advanced age, cardiac disease, previous stroke, tobacco and cardiac and renal transplant. For risk of rupture, female gender, decreased FEV1, large diameter, mean arterial blood pressure, current tobacco use. So all these are causes, risk factors for rupture. Now coming to the classification, according to the Society of Vascular Surgery classification, based on the extent and involvement of the renal and visceral arteries. So most commonly is the infrarenal, that is around 90%. So proximal level of aneurysm below the renal artery level with adequate aortic neck. So we can see in the diagram, we have sufficient aortic neck and below renal artery is the aneurysm. So we can place a clamp between the aortic neck so that we can repair it. Then juxtarenal or pararenal, it is around 8 to 10%. So proximal extent is at the level of renal artery. So there is no normal aorta between the aneurysm and the renal artery. So there is difficulty in placing the clamp. So clamp has to be placed above one or both the renal arteries for repair. Then suprarenal, where the aneurysm originates above the level of renal artery and may also have splanchnic involvement and requires renal or splanchnic revascularization before operation. The lesser common two ones like the pararenal and the suprarenal are more common in females. Then coming to the clinical feature, mostly these are asymptomatic and detected incidentally while working up for backache or abdominal ache. Rarely back pain or abdominal pain with pulsatile mass can be found, with most commonly in the supraumbilical midline. Tortuosity, infraumbilical, lateral can be seen. Ruptured aneurysm will present as back pain, abdominal pain, pulsatile mass with shock. So that is a very important finding, pulsatile mass with shock. And concomitant peripheral artery occlusive disease may present with renal artery disease and claudication. How do we evaluate? Ultrasound, which is a very first line and safe non-invasive way, limited to bowel, only limitation is bowel gas and body habitus. Then we come to CT, which helps us in CT angio, that helps us in defining the site, extent, vessel calcification, thrombus, and concurrent occlusive disease of the vessel. Anatomical information relevant for surgical planning is the length and diameter of the aortic neck, neck mural calcification, neck luminal thrombus, length and diameter of the common iliac artery, magnetic resonance angiography. That will be helpful, but it cannot detect calcification. So pre-op coronary and renal evaluation is important to prevent post-op complications. So what are the indications for intervention? Most commonly is the size, that is more than 5.5 centimeter, growth of more than 0.5 mm in 6 months or more than 1 centimeter in 1 year, saccular rather than fusiform, distal embolization, tenderness. These are all the indication for asymptomatic infrarenal aortic artery aneurysm. Also important is the size has to be considered. It is more in males and less in females. So it is 5.5 in males and 5 in females. Ruptured aortic aneurysm are surgical emergency, so has to be repaired in emergency. So what are the repair approaches? So approaches could be open, that is transperitoneal or retroperitoneal. In transperitoneal, we go for midline incision with left medial visceral rotation, that is METOX, where we explore the entire infradiaphragmatic aorta and is useful in emergency. In retroperitoneal, that is ideal for a juxta or suprarenal aneurysm, where the case when there is hostile abdomen with adhesion, but this is difficult and needs familiarity, so has to be a trained surgeon in that. Then rather an expert surgeon. Procedure: the aortic neck and the bilateral iliacs are dissected and clamped after hyperonization, and aneurysm is opened. Aneurysmal content are removed, that the thrombus is removed. Bleeding lumbar and inferior mesenteric artery are oversewn from within. Then aneurysmography is done by anastomosing a tube graft or a bifurcated graft proximally and distally. As we can see in the diagram, this is a graft or a bifurcated graft, and we repair the aneurysm sac over it. In case of a visceral, renal or branch vessel involvement, we reimplant it with a Carrel's patch or short bypass it or incorporate it together by careful beveling. So in case of ruptured aneurysm, if there is anterior rupture, which is in the peritoneal cavity in 20% time, in posterior rupture in the retroperitoneal space causing retroperitoneal hematoma in 80% time, only 50% are able to reach hospital because high mortality, and we should go for permissive hypotension, that is systolic BP should be kept around 100 or less than 100, and consider it a surgical emergency because of rapid loss of blood. Also we have an endovascular approach for repair, but it is not preferred if everything is all right, and it is preferred when in case of the patient is not fit for open surgery. Then complication of aneurysm surgery, these are wound complication, cardiorespiratory complication, ischemic colitis, renal failure, neurological complications like cord ischemia, sexual dysfunction, aortoduodenal or aortocolic fistula, graft thrombosis, occlusion, prosthetic graft with infection. Then we come for the endovascular management, that is endovascular approach, EVAR, that is endovascular aneurysm repair. It can be attempted in cases with long proximal aortic neck. neck diameter of around 1.8 to 3.2 centimeter, decreased mural calcification and decreased luminal thrombus, like less than 50% circumference of the diameter, and sufficiently long and wide iliacs. Technique is Seldinger's technique via the femoral approach at the L1, L2 level. Vascular closure device is deployed immediately below the lowest renal artery and verified with completion angiogram. Complication of this is endoleak with EVAR, then graft migration, graft fracture, graft limb occlusion, and needs lifelong surveillance. So this was all about abdominal aortic aneurysm. Now we'll be seeing in short about thoracic aortic aneurysm. So is the most common cause is degeneration, and second most common cause is late complication of aortic dissection, late complication. It could be in the aortic, ascending aorta, arch of aorta, or descending aorta. In the descending aorta, it is again divided into A, B, and C, where A, the aneurysm is above the level of 6th intercostal space. In B, it is below the 6th intercostal space, and in C, it is including the whole descending aorta. Then we have a Crawford classification of thoracoabdominal aneurysm, which is the central, including thorax and abdomen, wherein one, there is a complete thoracic, descending thoracic aortic aneurysm extending up to just below diaphragm. In type 2, it is thoracic and abdominal. In type 3, it is thoracic and abdominal but starts below the level of 6th intercostal space, and in 4th, it is below the diaphragm but it involves long segment of the abdominal aorta. Then clinical features mostly discovered incidentally as common and cause local compression and erosion, so can present as chest pain, back pain, SVC compression, erosion into SVC, right atrium causing heart failure, stretching of right RLN causing hoarseness, left RLN causing hoarseness, descending or thoracic abdominal vertebra erosions, airway obstruction, esophageal compression or dysphagia, then ascending aneurysm causing aortic regurgitation, then distal embolization causing visceral or lower limb embolism, rupture causing chest pain, shock, and cardiac tamponade. Evaluation will be done through chest X-ray, EC, which will show aortic silhouette calcification, especially in the lateral view. Echo will be showing, USG will be showing the basic defect, and CT angio and CT scan will be showing the site extent and other details, the calcification. Sometimes MRA can be used and aortography, cardiac catheterization may be needed. Then indication of intervention in ascending aorta, size is more than 5.5 centimeter, descending aorta more than 6 centimeter or 0.5 centimeter dilatation per year, lower threshold for connective tissue disorder, and in females, intervention should be open repair aortoplasty, usually with cardiopulmonary bypass, and endovascular repair, that is TVAR, thoracoendovascular aneurysm repair, or hybrid repair. So this was all about aneurysms and its management. So keep studying, keep growing. Thank you for watching. Please like, share, and subscribe, and never give up because great things take time. Thank you. See you soon in the next video.